very common in medicine for us to get findings that may be abnormal but not clinically significant to care. Like, they're actually very common. When there is a lack of clinical significance associated with a result, your doctor may say, let's just watch and see. So what the hell does it mean when your doctor says, you know what, let's just wait a little bit? Now, this is a question that I get quite often. I see it in y'all comments. Trust me, and as a patient, you are not the only one who experiences this. Talk to any nurse who has to call a doctor and report any abnormal labs, any abnormal image findings, and they will quite often hear their doctor say, all right, let's just keep an eye on it, but continue as going. And when you're on the other side, when you're the patient, when you're the nurse, when you're the person who's giving this news to the doctor and they give you that explanation, sometimes you could be left confused. Now, I can be honest, right? I am one where, because I recognize there's sometimes a bit of confusion or some concern, I will try to quell the concerns for especially my nursing staff and my patients, as I'm saying, let's just wait. Because for them, it's difficult for them to just kind of sit on ice because they don't really have the knowledge that we have as physicians and in our training. So today I'm going to talk about what your doctor means when they actually say, let's just wait and see. That way you don't go and, run and say, all right, this doctor knows nothing. This doctor doesn't care about me, because that tends to happen. Again, I see y'all comments, right? This is a very common question asked. So as we continue our series on what medicine gets wrong with the patient, today we're going to explore what your doctor actually means when they just want to wait and see. So I kind of talked about the scenario, especially when you're a patient and you come in to doctor's office, right? And you have a complaint, you have a concern, and your doctor does a pretty standard workup, whether it be lab work, whether it be some imaging. They do something that says, like, all right, we're getting the ball rolling. We're going to find an answer, because that's usually the crux of it. Hey, I'm coming with a problem. I'm looking for an answer. All right, let's do some things to find an answer. And then when I find something, you tell me just to wait, right? This is the position that a lot of patients are in, especially when they go to see the doctor or they're seeing a consultant and they have a problem that they've been dealing with, and they sometimes feel what I call limbo. They feel like they're in this state of like, okay, like, I know something is wrong. My doctor knows something is wrong because, obviously they're listening to me, they're doing tests. But now when the test comes back and it isn't completely normal, they say, you know what? I see that answer, or I see that result, but let's just hold off on it and just keep an eye. And that drives patients crazy. That drives nurses crazy. So we're going to talk again explicitly, because I understand, right? I understand being a patient. Like, if I was a patient, for example, I'm not a car person. So if I take my car to the shop, in fact, so as we speak, like my car's in the shop right now, there's like some safety belt recall. I'm not sure what's happened, right? But I saw the message that says, hey, there's some recall. I take my car to the shop. I can't imagine if I took my car to the shop after getting this alert that says, hey, there's some safety belt recall. And then the mechanic is like, oh, you know what? Let's just watch it. Right? Like I wouldn't be able, I'm like, hold on, I'm confused. Like, there's an error, right? It says an error. I get an email. I get an alert. It says, hey, there's some type of recall. I bring it to you. You confirm that there's some error or something abnormal, but you tell me just go wait on it and we'll keep an eye. Yeah, like, I'm going to be confused too. I'm going to be concerned. So again, I always like to give these examples because I think a lot of times, especially in medicine, especially as the doctor, right? As medicine, we sometimes don't really understand how our patients may be feeling frustrated, maybe feeling concerned, maybe feeling angry by our decisions. And I think this is one of the bigger decisions when we just want to have a wait and see approach to things. And a lot of times we don't do a good enough job explaining why we want to wait and see. Like I said, I deal with it with nursing all the time, right? Where they call me, there's some lab result that comes up. I say, oh, okay. All right, let's just keep an eye on it. Continue the same management. They hate that, right? In fact, and usually in their charting, they say no orders given, right? As if calling me with some abnormal lab test or imaging automatically means that I have to give you a new order, right? Like that's the standard default in their mind. So when I say, all right, yeah, we could keep on watching it, they say no orders given, because for them, the default is that I should be ordering something new based off this new result. So again, it doesn't happen just with patients. I can tell you, even within the healthcare system, there are people who really can't understand when the doctors want to wait and see. And today we're going to talk about why it's important, why the doctor tends to want to go with the wait and see approach, and even then, you know me, empower yourself for better health. Where are certain instances where you, the patient, could still be an advocate for yourself? Okay, let's walk down a patient's mindset, right? Let's call this patient Sarah. Sarah comes in, says, "Hey doc, like, you know what? I feel like a lump in my neck, right? I feel like I have a lump in my throat." Your doctor does what your doctor typically does. They do their physical exam. They ask their appropriate questions. Then they order a battery of tests. Let's say one of these tests happens to be an ultrasound of the thyroid, because again, when you have enlarged, masses in the neck, you want to make sure the thyroid is where the thyroid is. And guess what? They find a nodule, right? They find something, right? They get the right history. They do the right physical. They hear the right chief complaint from their patient, and then they find something. But then your doctor gets as results and says, "Hey, you know what? Based off the size of this nodule, we're just going to watch and see." So if you're Sarah, you did all the things you were supposed to do. Like you came to the doctor's office, because a lot of times y'all don't come to the doctor's office early. You came to the doctor's office early. You gave your concerns. Your doctor answered and asked the right probing questions, did the right test, found a result, and then said, "Let's wait." So Sarah's confused. Sarah's a little bit upset. Sarah doesn't understand, like, all right, how do I go from here? Because, like, clearly something is wrong. Because Sarah thinks something is wrong. But the doctor hasn't done a good enough job and just tells Sarah, "Hey, I'm going to see you in 3 months. I'm going to see you in 6 months. We'll rescan that later." So now, what does Sarah think? Like, put it in the comments. What do you think Sarah thinks she's got? Sarah thinks she's got cancer, right? Because all patients, anytime they have something, automatically they do their web search, they do their web MDing. Somehow, some way, cancer is always in the differential diagnosis. So now Sarah thinks she has cancer, and now she's heard her doctor say, "Hey, let's wait 6 months. We'll recheck that." Sarah, nah. Sarah's getting second opinion, third opinion, fourth opinion. All these doctors keep telling Sarah, "Yes, I see that you have a thyroid nodule, but you know what? Your labs are this way. And guess what? The size of the thyroid nodule means that we can kind of watch and wait." So this is, getting that real life scenario of where Sarah is. And why does Sarah feel this way? More importantly, like, what is it that medicine got wrong with Sarah that they didn't do a good enough job, right? So they didn't explain to Sarah, what does it mean to have some type of clinical significance? Quite often, especially when I'm taking care of patients in the hospital, when I'm taking patients in a nursing home, I will get calls about abnormal vitals. In fact, I probably get a call about an abnormal vital sign every single day of the week. Like, every single day of the week, I probably get a phone call about an abnormal vital sign. And you'd be surprised how often I actually have to do anything about the abnormal vital sign. Because again, I've been around the block. I've been practicing for over a decade. I've been practicing, which is so funny to say. I've been practicing for over a decade. I've seen a lot of abnormal vital signs. So I know when there's a concern for an abnormal vital sign, when there is something I should be doing about an abnormal vital sign, versus when I should be just kind of watching and see. So I try to do a great enough job to explain to whoever's calling me about the issue, hey, there has to be some clinical significance associated. Because having something abnormal, whether it be on a chest x-ray, having a lab value that doesn't fit the quote unquote normal range, there has to be some clinical significance associated with it. And quite often, not putting nobody out, but quite often, there's usually no clinical significance associated with the abnormal vital sign. They're just calling me because the screen says this is abnormal and they should call the doctor. And of course, I have to educate. So making sure and understanding, it is very common in medicine for us to get findings that may be abnormal but not clinically significant to care. Like they're actually very common. So when you hear that hey, it's not uncommon to have an uncommon result, some people kind of freak out. Some people are like, hold on, what do you mean? Like if this is an issue, why is it like not normal? Why did the radiologist? Because first of all, there's a lot of CYA, especially when it comes to imaging stuff, but neither here or there. So one, you have to explain to your patient you can find some things that may be abnormal but not be clinical significant, and that's an important thing. When there is a lack of clinical significance associated with a result, your doctor may say, let's just watch and see. For the example on the thyroid, a lot of times you'll have an abnormal thyroid nodule, but if it's too small, there's really nothing that they can do. So in Sarah's case, if no one educates Sarah, like, hey, I see a thyroid nodule, but it's so small, there's really nothing I can do about it. Sarah's going to think she has some full-blown cancer that like no one's paying attention to or no one's taking serious. So having to educate your patients or the nursing staff or whoever when there's an aspect of clinical significance is extremely important. And I think that's a big thing. This is another, I like this aspect here. Medicine, and this is probably a perfect example, especially when we talk about screenings. Medicine is a risk-benefit game. Like at the end of the day, medicine is a risk-benefit game. So if you have a situation where the risk of trying to go deeper, like let's say the thyroid nodule, it's so small that the risk of even me trying to do, let's say, a biopsy on that thyroid nodule is going to cause likely more problems than just kind of watching and waiting. You got to educate your patients. So understanding there is a risk for everything. I tell patients all the time, there is a risk when I give you Tylenol. There is a risk. In fact, I think a few years ago, I did this series on, I think it was on YouTube. Yeah, I think I did this series. If I find it out, I'll put a link in the show notes. But I did this series on just the risk of common medications we take every day. Aspirin, Tylenol, goody powder, like just things that we like, muscle relaxer, blood pressure medication. Like I just went down the list and said, hey, these are the risk of some of the most common medications you take. And people were surprised by how significant a risk can be. So understand that there's a risk and benefit for everything. When I give you a blood pressure medication, there's a risk that something may happen, but there's some benefits. When I give you a cholesterol medication, there's a risk that something happens, but there's a lot of benefits. When I give you aspirin, when you take ibuprofen for your headache, when you take Tylenol for a headache, there's a risk and there's a benefit. So you have to educate your patients on when the risk and benefit outweighs. Like when there's an imbalance where if I see, for example, if I see a chest x-ray and you have a large pulmonary nodule in there, the risk of doing nothing is so high versus the benefit of, you know what, I might need to send you to a thoracic surgeon. We might need to get a biopsy. Like all of those things that you may need to do that may be invasive. Yes, those benefits outweigh the risk of me saying, yeah, that's a large nodule in your lungs. Let's just watch it, right? You understand? Now you can kind of see, like, even though the other side is going to include more invasive procedures, more evaluations, more specialists, the benefit of doing that side is much better than the benefit of just kind of watching and waiting. On the other side, when we talk about screening exams, typically we will screen for prostate cancer at the age of 40, right? And that's, guidelines and everything else. And the reason why they do that is because they say, hey, if you start screening for prostate cancer at 25, the risk that you're going to get a lot of what we call false negative results is so high versus the benefit of the maybe 1 to 2 people that you catch with early stage advanced prostate cancer that, you know what, we got to move this thing to 35, 40, right? And again, that's where getting a good history of physical. Colonoscopies, yes. Usually at the age of 45, but some people need it at the age of 40. But guess what? Let's say you have a significant family history of colon cancer really early, in their 40s, early 40s. The risk of me waiting until you're 45 to do that invasive procedure, which is a colonoscopy, is much higher than the benefit right, of me doing your colonoscopy when you're 32. So sometimes the more invasive procedures, the more like surgical procedures, surgical testing, sometimes that benefit outweighs the risk of doing nothing. But it's up to your doctor, and more importantly, it's up to your doctor to help communicate to whoever needs to receive that information that the risk of just doing nothing, right, is lower than the risk of trying to like find out what's going on, right? So again, just to kind of give an idea, I love that aspect of risk versus benefit, right? Because I think that's a big issue that we're not doing a good enough job educating our patients on. Active monitoring actually is a plan. And I know you guys may not want to hear that. Like if I'm actively monitoring, if I say, hey, you know what, we're just going to watch this, come see me in 3 months, come see me in 6 months, come see, like we're going to keep an eye on this. We'll be repeating imaging. If I'm watching it, and again, I love the thyroid because the thyroid is such a great example. Often or not, because I take care of patients in nursing homes, often or not, patients will come from the hospital with an abnormal thyroid level, very often. And most of the time, I'm not taking care of a patient for more than 2 to 4 weeks at a time anyway. Like, they're in there, they're getting their rehab, they're getting out. And sometimes the nurses will call me and say, oh, the thyroid's abnormal. Do you want to adjust this person's thyroid medication? One, if you understand how thyroid medication works, and more importantly, how the thyroid hormones work, is that anytime you're sick and ill, they can fluctuate. So this person just came from the hospital. So this person is ill for whatever reason, right? Maybe even if they got an elective procedure, something had to get done. So your thyroid hormone can, fluctuate to the point where it comes back abnormal. And for most people don't understand, it usually takes about 3 to 6 weeks for any changes on your thyroid hormone, especially if you adjust a person's medication, to see some results. So if I'm only taking care of a patient for 2 to 4 weeks, even if I make that change, I'm not going to see the end result of the change for another, 3 to 6 weeks. That person might be gone by the time I see them. And I don't want to be making changes. Remember, the risk of making a change is higher than the benefit of just kind of watching and following up with your primary care doctor, right? But the goal in the plan of following up with your primary care doctor to repeat the test is a plan. So understand that just because we say we're just going to watch it doesn't mean that we're going to close our eyes and act like it's not there. No, we understand. We're like, all right, yep, I got to keep an eye on that. Yep. Sometimes a lot of our, electronic medical records will make sure we keep an eye on that. They'll give us notifications. So understand, watching is a plan. Even though I know the nurses will say no orders given, you could say Dr. Pierre said continue to monitor. They don't do that, but whatever. Again, we're not putting that on my nurses. Shout out to my nurses. We love y'all. And this, I think, is the important thing where my patients have to step in, right? Because again, medicine gets it wrong with patients because they don't do enough job educating. The patients get it wrong because they will forget as well. So they got the thyroid hormone, they'll forget to follow with the doctor, right? I missed the appointment. Next thing you know, 1 year later, boom. I missed the appointment for my repeat ultrasound. Next thing you know, boom, right? So as a patient, you have to stay engaged as well. You have to be an active participant. You can't be like, oh, my doctor said, you know what, just keep an eye on it and I'll just defer to the doctor. No, as the patient, you have to be your own advocate to make sure when month 3 comes by, you're calling the doctor and say, hey, remember that thyroid nodule you said we were going to repeat? It's time to repeat it. Right? Hey, you remember when you said I was too young to get that colonoscopy? It's time. I can get a colonoscopy now, right? So understand that it's up to the patient too, right? It's not a one size fit all, it's all on the doctors. Yes, it's important for the patients to understand, oh yeah, I gotta get on it. 3 months, I need that repeat testing. 3 months, 6 months, I need that repeat imaging. Oh, the nurses, you know what? Dr. Pierre said if something changes, give them come on, we got to do what we have to do because, and I love this factor here. Good communication prevents anxiety. And what I see all the time is an anxious mind is a confused mind. A confused mind will start making up stories. If you are confused, you will start making up stories. You will figure out a way to diagnose yourself with cancer if you are confused. And it usually borders on the fact that you are anxious because your doctor did a good enough job actually communicating, hey, when we're watching, we are actually doing work. And I understand that you think watching is nothing, but trust me, the risk of trying to do something and trying to look for something, trying to do something more invasive is going to be much more harmful to you than me just kind of just watching and waiting. So I think you would appreciate me just kind of watching and waiting. So understand that when you have good communication, you reduce your patient's anxiety. If you reduce your patient's anxiety, guess what? They're less confused. And if they are less confused, they make up less stories. And we want them to make up less stories because that's how they stop diagnosing themselves with cancer, right? Because they're not making up a story of cancer. We don't want them to know cancer, right? I hate you. I really hate WebMD for that. And not that I hate WebMD because WebMD provides information, because I think it's important. Obviously, you guys follow me, you guys watch me because I provide great information. But because the disclaimer, because WebMD is never going to get caught up and you missing out your headache being cancer, WebMD is always going to include that cancer to say, go take yourself to that Dr. Pierre because you might have cancer, right? That's why my terms and conditions says, go find your doctor. I'm not your doctor. Go find your doctor if you got a problem. These are some big ones. These are some myths that I want to make sure we get up out of here. No action means no problem. Again, that's not true. That is not the case. You got the thyroid nodule. You have an abnormal liver enzyme. You have an abnormal chest X-ray. It just doesn't need to be worked up completely right now. It needs to be worked up. And maybe let's say, perfect example, EKG. You got an EKG that's not typically, it doesn't say normal, right? Your primary care doctor, right? Shout out to my primary care doctors. A lot of them can't read EKGs. If it, like, they look up, it says something different from normal, they send you to the cardiologist. That doesn't mean you need to go to the hospital to see the cardiologist. You may just need a regular follow-up scheduled for your consultation for the cardiologist, who may see you in like a month or two, right? Like, that is possible. So understand that just because we say, right, we're not going to take any action right now does not mean that there is no issue, because there could be an issue, but the risk of doing something right now is so high that we just want to watch and wait to make sure there isn't any problems. Because again, there's more benefit from watching. When the benefit of watching supersedes the risk of doing something, guess what? We're going to always watch, because that's what we trade for. That's what they trade us for. That's what I guess they quote unquote pay us the big bucks for, to recognize when can I watch and when can I have to like take into action. When can I just say, hey, you know what? Take this medication right here versus nope, you're going to the ER right now. Right? Unlike my ER docs who admit everything, right? Because for ER, everything has got to happen right now. But primary care, internal medicine hospitalists, we recognize when like, you can go home for that. You don't need to stay in the hospital for that. Or, you know what? Take this medication here. See me next week. See me in a month. We recognize where severity lies. Assuming one size fits all, never the case, right? So again, just because someone ended up having to go see, a vascular surgeon or a thoracic surgeon with their thyroid nodule, doesn't mean you need to. You may just need to see the endocrinologist, right? Again, one size does not fit all. So don't listen to your friend's story and assume that your friend's story has to match your story as far as the workup is concerned. That's usually not the case. And then remember, self-diagnosing or self-treating out of fear. Don't do that, y'all. Don't do that, y'all. Especially for those, right? And we talked about this. I think it was early last year of, the woman who was diagnosed with breast cancer and decided, you know what, I don't want to go the traditional route of treatment. I'm going to take these supplements, right? And of course, y'all know what happened, right? Like self-diagnosing, self-treating can be extremely harmful because, again, like I said, it's that risk benefit, right? Once that risk of you doing nothing, once the risk of you doing nothing is so heavy that the benefits are way out the screen, you got to do something. And you got to do the right something, right? Because it's not one thing to just do something. You have to do the right something. So very, very important when we talk about, kind of risk benefit of kind of doing things and, the dangers of self-diagnosing and self-treating, right? I don't want y'all to do that, right? Like, that's just crazy to me. So before we get up out of here, right? Again, we just want to recap. We just want to recap what's going on. My doctor said, I come with my doctor, there's an issue. My doctor finds some issue, but says, let's wait on it. Does not mean your doctor is ignoring you. It does not mean your doctor doesn't care about you. It does not mean that, like, oh my God, your doctor's going to miss this cancer. It does not mean that. It just means that the risk of doing something is much higher right now than the benefit of just kind of watching and waiting. And watching and waiting is an order. Like, watching, it's not a no new orders. No, I want to watch and wait and see what happens, right? That is an order, right? Again, I keep sticking it in there, right? I got a lot of my a lot of nurses and nursing staff who work at some of the nursing home facilities who watch me, so they'll get a nice laugh at this, right? But like, it's very important to just understand that, yes, when we are watching, we are doing something, right? But as the patient, still remember, it's still okay to be an advocate, but at that point, your advocacy comes in the follow-up. Hey, doctor, you said see me in a week. I'm here in a week. You said we're going to repeat tests in a month. I'm repeating that test in a month. You said we have to do this imaging in 3 months. I'm doing it. You say I got to wait till I'm 40 to get a colonoscopy. I just turned 40 yesterday. Give me the colonoscopy, right? That's where your job as the patient comes in the advocating of yourself. But trust me, trust and believe that your doctor has your best interest at heart. So when they say they want to just watch and wait, it's because they understand, like, you know what? Let me take some of that anxiety from you. Let me take away some of that confusion from you, and let me deal with that burden, right? So again, I am yours truly, Dr. Barry Pierre. Welcome. And again, thank you for watching another episode of Medicine Mondays in our series of what medicine has gotten wrong about the patient. I'm going to see you guys next week.